I have three main rules when it comes to tendinopathy management or tendon management in general. The first being, make sure the diagnosis is a tendon problem. Make sure you have the right diagnosis. Tendinopathies absolutely occur. Most often they occur at the Achilles, in the ankle, the patellar tendon in the knee, the supraspinatus tendon in the shoulder, and both the lateral and medial tendons of the elbow. They can occur other places, but they are primarily there. Making sure is a tendon means making sure the specific verbal history gives us clues that the problem is indeed a tendon pathology. Secondly, making sure that the orthopedic baselines match up. And third, making sure that the testing that we use confirms that diagnosis. When I think about the specific verbal history for a tendon problem, I'm usually wanting to hear there was an abnormal or new force on a tendon. There can be other maybe predilections for tendinopathies such as insulin resistance or frank diabetes, some sort of metabolic derangement. But usually the impetus is a new or abnormal force on a tendon, like moving furniture for the last week, or starting to play tennis, or ramping up your running training. So I'm listening for that. There's usually a notable history of that the patient can recall. There are other things, but that's the most kind of pertinent piece of information when it comes to taking the specific verbal history. Secondly, the orthopedic baselines need to match up. This is where I think clinicians and maybe patients alike find things that don't really match up with the diagnosis of a tendinopathy and tend to just wave them off and say, well, they don't really matter. A mentor of mine said, you can focus on the 19 things that corroborate the diagnosis, or you can focus on the one thing that doesn't. And I ask patients, and I ask clinicians especially, focus on the one thing that doesn't, because that could disprove all those other facts. If you have a biceps tendonitis, for example, or tendinopathy, which is not that common at the elbow, but for this purpose of demonstration, it's easy. So this thick tendon in here, you can feel it, your biceps connecting to your elbow. Well then, what would I expect in the abbreviated baseline taking? I would expect that resisting biceps motion, so elbow flexion, would produce weakness and or pain local to that tendon. In terms of range of motion, I would expect no real loss of range of motion in terms of obstruction. For example, if we go into full elbow flexion, that biceps tendon is on slack. It's not doing anything, it's not being stretched, so there should be no obstruction or limitation with this movement, nor pain really. When it comes to elbow extension, in some cases that tendon might be so inflamed or shortened that getting to full extension might be challenging, but I don't see that in most cases. And it wouldn't feel like an obstruction. It would feel like the person saying, I just can't go because that stretch is so great locally in that tendon. I would expect other things to be normal. Shoulder range of motion to be normal usually. Wrist stuff, no nerve tension, no relevant loss of motion in the spine. So the main things I'm looking for are at that elbow local to the tendon and at the action that the tendon does, which is elbow flexion. When it comes to testing, we can, for certain tendons, we might have a few more specific tests, but I'm really looking at repeated movement testing to help me rule in or rule out tendinopathy. If I do repeated movement testing of the neck, mid-back, or elbow joint in this scenario, and the baselines change, well then that likely rules out a tendinopathy, because I don't expect that moving the neck or moving the mid-back or moving the elbow joint would change a tendon problem, because we're not addressing the tendon. So that's the test that I find to be the most important, because it can really rule in or out a tendon problem. If I move the joints and there's no effect, oh, it's still painful with resisted biceps and some weakness there as well, we still have some aggressive stretch on the tendon when we go into elbow extension, then we can more firmly rule in the tendinopathy and go with the management process. That's why I think repeated movement testing is so valuable as part 3 of my orthopedic evaluation. Rule 2 for tendinopathy management means let's do progressive loading. So once we've established that the diagnosis is in fact a tendinopathy, we want to produce the patient's concomitant pain with loading of the tendon, whether that's isometric, concentric, or eccentric loads. And I want patients to do it several times a day, producing their symptoms, and we will change the load once the symptoms go down to 0 or close to 0, because we want it to be productive. We want to produce the patient's pain that they're complaining of. So for the biceps, it could be its most provocative just with simple elbow flexion with a weight. Again, it could be isometric, it could be eccentric, where you're asking the tendon to lengthen under load. It could be some kind of idiosyncratic movement where it's really provocative with the elbow in pronation or supination, or with it being in weight bearing versus non-weight bearing. So we try to find, again, that loading strategy that recreates the person's complaint. And third in my rules is to address any risk factors or any kind of sources of problems that we think may have led to the tendinopathy. They're not always there. Sometimes it really is as simple as too much training too quickly, for example. But other times I think we can find things that really predispose to that tendinopathy. Not everyone who moves furniture for a week, of course, has a tendinopathy. Not everyone who takes up tennis has a tendinopathy. So what are either maybe metabolic problems that are underscoring this, or musculoskeletal problems or others that may have predisposed the patient to this problem? So when it comes to the example I gave with the elbow, let's see, maybe you were missing some range of motion in your shoulder or your mid-back. Or maybe if you're playing tennis, you're not holding the racket correctly, and a tennis coach could address that. Or if you're running, maybe you developed an Achilles tendinopathy because your stride is too long. Or maybe you adopted it because the shoe wear is not best for you. We gotta look for those factors so that we can understand the problem more fully, and try to prevent recurrence, of course. But I think of those three, most clinicians agree with numbers 2 and possibly 3. The first thing though, making sure it's a tendon, I think we're missing. I think a lot of patients are being told they have tendinopathies when in fact they have joint mechanical problems, which resolve much more quickly, which is a good thing, but instead they're undergoing weeks or months of tendon rehab. So make sure you can get the right care, and that's based on getting the right diagnosis from the start.